Okay, I think we are live now. Hi everyone, thank you for joining me today. Given the current situation in the world, I sincerely hope that you and your loved ones are safe and doing well. I urge you all to follow all the precautions given by your government and the WHO. From all of us at EndoStar here, we request you to stay home and stay safe. Okay, moving on. I hope all of you all have your coffee mugs ready to join me in this session of on Endo Coffee. Okay, let me start by introducing myself. I'm Dr. Nikhil Modi from India. I've been practicing as an endodontist for the past 8 years. I did my education from the University of Manchester in the UK. So today I would like to discuss this topic called modern access designs in endodontics. Now this is a huge topic to cover in 20 minutes. So I'm going to talk about a certain method that I use in some of my cases, and I'm going to try and keep it very brief. Okay, let's dive right in. We had already begun redefining and reconceptualizing endodontic access in the 90s when the first generation of rotary NITI files were introduced. Back then, these files were quite large and stiff compared to the standards today, but still, they helped us develop a completely different conceptualization of straight line access when compared to traditional hand files. Dr. Buchanan recently wrote, "Errors accumulate during procedures. That's the reason botching the access at the start of a root canal is so much more devastating than the problems that may come from misfitting GP cone just before finishing the case." The importance of endodontic access continues to this day in the textbook Pathways of the Pulp, which states access to complex root canal system is the first and arguably the most important phase of any non-surgical root canal procedure. What does all of this mean or imply? It means that even if you have a beautifully done root canal, but if your access is not good, the tooth is not going to have a long life. What I just said is backed by this article from 2014 by Ellen Mayer. It stated that creating more conservative access openings can reduce the risk of tooth loss related to weakened tooth structure. Significant problems usually are more related to the loss of the tooth structure than the endodontic procedure themselves. A PhD professor called Ursula Franklin once said, "Every tool shapes the task. Any task tends to be structured by the available tools. It can appear that the available tools represent the best or even the only way to deal with the situation. However, new tools and instruments may redefine the problem and thus the approach to the problem." What does this mean? This means with new technology, there are new possibilities to solve any problem. Who would have thought back in the 80s or the 90s that today we could have this webinar sitting in our houses from different parts of the world? With the internet today, this has become a possibility. Similarly, in endodontics, we have seen so many advancements in the last few years that may provide us better solutions to save teeth and add to their longevity. In healthcare, minimally invasive procedures are a welcome concept across all fields of practice. After all, who wants to be maximally invasive in their healthcare procedure? So when it comes to endodontics, the question to ask is whether the current methods are adequately minimally invasive or whether a more minimally invasive method should be implemented instead. considering the advancements in the technology we have today. Now, Dr. David Clark and Dr. John Khademi were amongst the pioneers who started this shift from traditional access cavities to more conservative designs. Here are some of the cases which they did along with their colleagues. You can see a case of Dr. Buchanan also present in here. Today, a lot of clinicians regularly use minimally invasive methods to save teeth. Dr. Viraj Vora from Canada and Dr. Ruben Joseph from India are few of these skilled clinicians. Here, Dr. Vora has used a Ninja Access to treat this tooth, whereas Dr. Ruben has used a caries-driven access to solve his case. This is one of my cases where there was a cervical caries defect, and thanks to the new flexible Azure files, I could approach this tooth from the buccal aspect and treat it, preserving a lot of sound tooth structure. Here is one more case of mine where I used the caries driven access thanks to these new flexible files. In the recent past, a lot of advancements have happened in the field of endodontics, namely the nickel titanium files were introduced, followed by microscopes in endodontics, and more recently the CBCT, which has great use in endodontics. All these advances help us or bring us closer to the aims of minimally invasive endodontics. One such milestone or an advancement is the Azure HT technology. Now I know there are a lot of heat treated files on the market today. Then what is so special about Azure? To understand this, we need to understand a bit of material science and metallurgy. Now what exactly is heat treatment? Well, it's nothing but a series of heating and cooling procedures that have been applied to the nitide to modify its properties. In regard to endo, these properties are mainly flexibility and strength. Each company has their own unique recipe to bake nitide and program it in a certain way. Every recipe gives you a completely different end product. Remember, no two files from different companies which are heat treated will act the same, because each of them has undergone a different heat treatment. Let me throw light on this. Have a look at this video. Here I have hot water in this cup, and I have few heat treated files belonging to different brands. When I place these files in this hot water, some changes happen, as you can see. When you take a closer look, you see some files have straightened up completely, whereas some of them have not really changed their shape. Why does this happen? Because each of these individual files has been programmed to act in a certain way at a certain temperature. That's why they act differently. Now we all know nitide exists in two interchangeable states, the austenite and the martensite. During phase transformation, the nitide undergoes an intermediary phase known as the R phase. Most files available today are a mixture of these three phases in different content. The martensitic phase is the most flexible phase, followed by the R and then the austenite. However, the austenite has the best cutting efficiency compared to the other two phases. This means the more flexible your file, the less is its cutting efficiency. This is the reason why most super flexible files unwind quite easily during use, as they have a high martensitic content. This compromises the cutting efficiency. Most companies have tried to strike a balance between these two phases and aimed at giving you best of both worlds. But in my opinion, what they have actually managed is to give you a product with mediocre properties from each phase. Okay, now phase transformation usually happens in two ways. It's either due to heat or either due to stress. Let's talk about heat-induced phase transformation. Have a look at this graph. This is a very important slide. Now the red line here indicates as the martensitic phase is heated, it transforms into the austenite. And the blue line indicates as the austenitic phase is cooled, it transforms back into the martensite. The four temperatures here, namely MF, MS, AS and AF, which are marked, are extremely important. All the brands play around with the values of these four temperatures mainly to give you your end product. Now, if you see the gap between these two lines, the blue and the red line, that's where the R phase exists. Usually this gap is around 20 to 30 degrees in most files. Now, I was explaining what's so different about the Azure. Please stay with me. The people here at EndoStar have programmed the NiTi to have its AF at 36 or 37 degrees Celsius, that is almost at body temperature. This means as soon as you place your file into the canal, it transforms completely into its austenitic phase, thus giving you super cutting efficiency. Yes, now you all might be wondering, if the file is already in its austenitic phase, how do we address the flexibility? To explain this, let me go back a couple of slides. Remember I told you there are two ways phase transformation happen? Now let's talk about the stress-induced phase. Now stay with me. Now when your file is in the canal, it's transformed into the austenitic phase because of the AF being at body temperature. Now as the file rotates in the canal, there are certain points on the file which are under stress. NiTi has this inherent property like some other metals that when under stress it transforms into a softer phase, which is nothing but the martensitic phase. Now what these guys have done is they've kept this R phase interval between the two phases to a minimal 2 to 3 degrees Celsius. To have a stable R phase in such a narrow gap is very difficult. So what is happening inside the canal is all the points along the surface of the file which are under stress are being transformed into the martensitic phase, and as soon as they are out of stress, they are retransformed into the austenitic phase. Thus, it's almost as if your file is self-healing itself inside the canal. I hope you all understood this. This actually is a graph from their internal study. Like I was saying, have a look here. The temperature gap where the R phase exists is minimal up to 2 to 3 degrees here. Thus, martensitic phase, which has the greatest flexibility, almost immediately comes into play when the file is in stress. Okay, that is why you get actually the best of both worlds, super cutting efficiency of the austenitic phase as well as super flexibility of the martensitic phase. Okay, moving on. Back to our topic today. So, I want to talk about something I use quite often in my practice these days, the truss axis. The truss axis involves orifice-directed separate axis cavities for the mesial and the distal canals, leaving behind the dentine over the roof of the pulp. This may help prevent gouging of the lateral walls and add to the structural integrity of the teeth, mainly having MOD cavities. There are very few studies showing the impact of such an access on fracture resistance. One such study by Dr. L. Naga does say that the fracture resistance in teeth treated with this access is better than traditional access cavities. However, this is still a debatable topic and more studies are needed. Now the right armamentarium is required to attempt this access. Firstly, you need magnification. Do not try and attempt this without magnification. Also, ultrasonics prove extremely helpful in preserving any dentine which is not in preserving dentine. Thirdly, and most importantly, you need files that you can trust blindly. For me, these files are the Azure files. Azure has helped me deal with multiple cases of different anatomy, namely the entomolaris, severely curved canals, and also toroodont. Okay, this is one of the cases I did recently. You can see it was already heavily restored, so I wanted to preserve as much dentine as possible. Here I've accessed canals to different separate orifice directed accesses and preserve this part of dentine in the middle. This is the final result. This next case was performed by me on someone who came in at the very last minute before being deployed to the ship for 6 months. So basically he didn't have time to make a full coverage crown. Thus, I wanted to save as much tooth structure as possible to maintain its integrity. You can see there is mesial and distal decay over here. So if I would have gone with a conventional traditional access, I would have been left only with the buccal and lingual walls here. This was the pre-op photo. Pre-endo build-up was done first. Followed by the pre-endo build-up. This tooth had a huge pulp stone. Have a look at the amount of tooth structure which I could manage to preserve here. U files were used to remove this pulp stone. Alternatively, you can use sonic files from EndoStar as well for this purpose. They are less aggressive. Following the removal of the pulp stone, proper cleaning and disinfection was done. You can nicely see all the canals here being irrigated. The endo activator was used for agitation. This is post cleaning and shaping. This is the cone fit photo. It's post-op. This is the final result. I hope this tooth survives for a longer time till the patient comes back in for a crown. Dr. Viraj and Dr. Rubin, whom I mentioned before, regularly use this type of access in their practice. These are few cases done by them. Now, case selection is extremely critical when you want to attempt this access. Usually, I prefer using this in cases with proximal caries or previously failed mesiodistal restorations. Make sure that the pulp canals mesiodistally is wide. Also, the tooth must be accessible. Here you can see, in spite of this limited access, I can irrigate the tooth very well. Okay, why complicate our life? This is one of the most repeated questions when it comes to conservative or modified access. The answer is simple. Because the suggested access design, when it is performed with experience and with the updated technologies, while respecting all of the parameters, errors can be avoided. Not only will the tooth be treated in a safe and healthy approach that will preserve valuable tooth structure, but the short and long-term success will be improved as well. I would like to conclude this discussion with these comments. Conservative access endodontics has challenged the traditional conventional approach in these recent years. Truss access mainly emphasizes on the preservation of healthy tooth structure with minimal invasion. Researchers and clinical evidences of truss should be performed in endodontics to help conservative access openings to overcome traditional access openings, thus changing the paradigm of endodontics to conservative endodontics. Well, I think that was 20 minutes from me. I hope you guys found this lecture, rather discussion, interesting. I would like to welcome Dr. Oleg for the next session of Endo Coffee, which will be held on the 3rd of April. I think I have some time to answer any questions if you guys have. Just hang in there. Let me just check. Okay, if you all have any questions later, you can private message me and I'll try to answer those questions later. Well, somebody asked how do you remove the pulp stone beneath the tooth structure? They say it's a task even with ultrasonics. Well, in the video I showed you, you can use U files from Money or endosonic files from Endostar to do the same. Yes, it will take some time, but you need to have patience when you are treating teeth with such conservative access. Any haste might cause unnecessary extra problems which you don't want to encounter when you're dealing in such a tiny space. Okay, there's one more question. Do you change the pre-endo composite build-up while your co-build-up? Well, there are different schools of thought here. I leave this honestly to my restorative colleague who does mainly the restorative part of the tooth. But usually I feel a monoblock would be more helpful in such cases. So whatever you make for your pre-endo build-up, remove that and build it up again so that it becomes a monoblock and adds to the strength of the tooth. Okay, so you all can send me questions later. I hope you guys enjoyed this discussion and please stay home and stay safe.